essentials of breast surgery and what a surgeon must know. Now, whenever you're talking about breast surgery, it is difficult if you do not allude to history first. And this is how I'm going to talk about some theories which were put forward by our seniors in breast surgery. And one of the most important theories which was put forward was by William Halsted, and he had said that breast cancer starts as a local disease in the breast, and in contiguous fashion, it spreads to the lymph nodes and then to various organs. Now, based on this, he devised a surgery or an operation which is called as Halsted Mastectomy, and he was very radical in his approach. He believed that since it was a local disease, a more radical local treatment, which is removal of the breast, removal of the underlying muscle, removal of axillary glands, and removal of supraclav glands, would treat the breast cancer. But that was not going to be so. But that was the onset of a good surgery in breast cancer. Now, after a couple of, about 50 years, Professor Bernard Fisher came in, and he believed that breast cancer at its onset was a systemic disease. And this was his alternate hypothesis. And he believed that variations in effective local regional treatment are unlikely to affect the survival substantially. So with this mindset, he published and he conducted and published a lot of studies, and the trail of studies that followed and that changed the breast surgery forever were, the first one was NSABP04, and we have a 25-year follow-up on that, which compares radical mastectomy with a total mastectomy and total mastectomy followed by irradiation. Now, this radical mastectomy is actually the Halstedian radical mastectomy. And he was able to say that total mastectomy, there was no difference in survival between radical mastectomy, and total mastectomy followed by irradiation. The next study that followed was NSABP06. And in that, he was able to establish, I'll be alluding to NSABP06 later in my slides again, and he was able to prove that even if you did a breast conservation surgery, the survival of a breast cancer patient would not change. Overall survival of a breast cancer patient would not change. The next theory was the spectrum theory, which was given by Dr. Samuel Hellman, and he believed that breast cancer was neither just a systemic disease and nor just a local disease, but it is in fact a spectrum where some disease may present as local first, while there are some which may be systemic when they are first detectable. Now, there are proponents of each of these theories, but what holds true right now and what most people practice is what Dr. Bernard Fisher said. Now, from history, we move on to incidence of breast cancer. And I don't think any talk on breast cancer can be complete without mentioning that breast cancer is the most common cancer in the world in women. And it is, like you can see, this is from Globocon, updated data of Globocon 2020, and it shows that the situation is extremely same in Bangladesh as well. Moving on to the symptoms that the patients present with, and the most common symptoms is a painless lump in the breast or occasionally in the axilla. Because it is painless, most patients ignore the lump. The other symptoms that can be present are nipple discharge, skin ulceration, puckering, dimpling or hardening, a recent change in the shape, size or feel of the breast, any swelling in the axilla, change in shape of the nipple or areola, retraction of the nipple, or symptoms which are referable to metastatic site if they are present. Signs, when the symptoms are converted to signs, and what you see is a breast lump, a lymph node in the axilla or a supraclavicular area, skin redness, ulceration, skin nodules over the breast, fixity to the underlying muscle or chest wall, and there are signs which are referable to metastatic sites like bone pain, cough, or there are other signs as well. Now, whenever we are talking about treatment of breast cancer, it is absolutely essential that it is always a multidisciplinary decision that is taken, and it is shown in multiple trials that a multidisciplinary team or a multidisciplinary decision for breast cancer treatment is much better than one of the oncologists taking the decisions. And the MDT in case of breast cancer would be breast surgeons, radiation oncologists, medical oncologist, breast pathologist, radiologist, and physiotherapists, occupational therapists, nutritionists, and even counselors. Now, moving on to how you manage breast lump. So the most important and it's an essential test that you do is the triple test. The first component of the triple test is a clinical history or examination, which all of us are already aware of. The next test that needs to be done whenever there is a breast lump is a diagnostic mammogram. Now, most of the time, a mammogram is able to give us the location of the tumor, the extent of the tumor within the breast, or presence of any other tumor in the same breast or in the opposite breast, presence of microcalcifications. Now, if, especially in younger women, when the women who have denser breast, ultrasound or an MRI is used as an adjunct to the diagnostic mammogram, and that helps in determining what the extent of the disease is. Using a more sensitive test like the MRI as the primary investigation for breast lump is fraught with false positive, multiple number of excess biopsies, and sometimes even more mastectomies than really required. So MRI is not a must for all breast conservation surgeries. It is done only when there is an indication like a dense breast, or there is when you're trying to screen for genetic patients with genetic mutations or of higher relative risk of having breast cancer. The next thing, or the next part of the triple test, is an FNAC or a core biopsy. Now, either of these can be done. FNAC has more both false positive and false negative. Core biopsy yields more information. We are able to know a lot of other things, which I'll be alluding to in the next slide. But it is important sometimes that whenever we are doing a core biopsy, it can be either an ultrasound-guided core biopsy, or it could be a blind core biopsy. And especially the tumors that we see in our countries, India and Bangladesh, I think we are generally able to do a blind core biopsy where we can just take the lump in the hand and we can do a core biopsy with a gun. Now, once the core biopsy is done, it is essential that there is a way to mark the skin. So what we do at Tata Memorial Hospital is that we take the core from the summit of the tumor and take a linen stitch on where the core needle is inserted. Now, the linen stitch does the job of having a little bit of inflammatory changes near where the stitch is taken, and which causes a permanent mark. And this mark helps us. Suppose if we have to give chemotherapy to this patient, this marks help us locate the tumor where it was at the end of chemotherapy. The other methods for how you can really mark this tumor is if finances allow and if the patient is comfortable, we can place a clip within the tumor in the breast, and the clips can be placed at the center of the tumor, believing that there is going to be a concentric response, or it can be put on the peripheries of the tumor. But then if you're putting it at periphery, the number of clips include, and each time a new clip is put, which costs about 10,000 Indian rupees. And that makes it about 4 or 5 clips placed in a patient, makes the biopsy very expensive, and a lot of patients are not able to afford it. Now, what are the components of core? What are you looking at? What is the benefit of doing a core over an FNAC? One, you get to know whether there is an invasive component in the core biopsy, as well as a non-invasive component. You also get to know that there are what the hormone receptor status of the patient of the tumor is, whether it is estrogen receptor positive, progesterone receptor positive or no. We get to know the HER2 status of the patient, of the tumor, and it can be reported as 1+, like all of us know that it can be reported as 1+, 2+, or 3+. If it is 3+, it is positive, 1+ is negative, and we need to confirm it with FISH, whether amplified or not, if the HER2 is reported as 2+ on IHC. The other thing that has been added to core biopsy, the report of biopsies, is Ki-67 score, which tells us whether what is the proliferation index of the tumor. And for patients who cannot afford to have an oncotype DX or other genomic markers, Ki-67 sometimes in a very small number of patients lets us decide whether or not this patient is going to benefit from chemotherapy or not. There is a IHC4 score also, which helps us decide whether the patient will benefit from chemotherapy or no. Now, once we have done the triple test, we've taken a history, and we've done a clinical examination, mammography, and a core biopsy, we are able to differentiate the breast tumor, or classify the breast tumor into an operable breast cancer or a locally advanced breast cancer. For the locally advanced breast cancer, what we do next is a step which is called the metastatic workup. It can be done by chest X-ray, ultrasound, or a bone scan, or a CT scan or a bone scan, or a whole body PET-CT scan. Now, like all sensitive tests, PET-CT is again fraught with a little bit of more false positive tests. So we do it sparingly, and we do it only because we feel that there is difference in investigation, finding investigation. So after the metastatic workup, we are able to classify it into locally advanced breast cancer versus a metastatic breast cancer. Now, once this has been classified, the role of surgery is there in all the three subsets of breast cancer, which is operable, locally advanced, or metastatic, and I'll be coming to it. Now, the surgery which is available that we do is modified radical mastectomy or breast conservation surgery, which can be with oncoplastic reconstruction or without oncoplastic reconstruction. Dr. Shalaka after me is going to allude to is going to speak about the oncoplasty, but I'm going to talk about the basics of breast cancer surgery. The breast conservation surgery includes lumpectomy, axillary surgery, and locoregional radiation. Now, what is better? Is it safe to do BCT? Like I told you, in NSABP 06, we have a 20-year follow-up now, and it shows that there is no difference in overall survival in either of these three arms, which included lumpectomy plus RT, or total mastectomy. Now, what are the contraindications to breast conservation? Now, I know these have been classified as absolute and relative, but they're not completely, there is no real absolute contraindication. So in a pregnant woman, except for third trimester, it's difficult to do breast conservation because giving radiation to her may be difficult. But then if you do it in the second trimester and you give chemotherapy after that, then radiation may be possible once she is delivered. In multicentric disease, now in multifocal diseases, we are able to do conservation, but in multicentric disease, it is not advisable to do breast conservation surgery, and it must not be done because the chances of local recurrences are much higher. If there is no way that you can irradiate the chest wall, or if you cannot give radiation post conservation, then that patient has a contraindication for breast conservation surgery. The relative contraindications are when the breast tumor ratio is not favorable to this. You could give chemotherapy or neoadjuvant hormone therapy and make it amenable to conservation. Or if the patient has collagen vascular disease, which is active, or an autoimmune disease, which is active, giving radiation may be difficult post-surgery, and that's why it is not advisable to do breast conservation for these patients as well. Now, when we are doing breast conservation, the two components of the two surgical components of it include lumpectomy. Now, when we are doing lumpectomy, it is important that what we try and do here is that take a margin of normal tissue around it. How much margin needs to be taken, I'll be talking about it later. But it is important. What we do is we orient the specimen as short superior and long lateral with 2 threads, and a skin pedal can be kept on the anterior surface, or like you can see here, there is a wire coming out of the specimen, and so we know which is anterior, which is lateral, and which is superior. And once the lumpectomy is done, and I think all the radiation oncologists will completely agree with me that it is of utmost importance that the cavity is marked. Once the tumor has been taken out, the cavity is marked with the Liga clips. We use Liga clips, and we use the medium white ones. We mark the cavity with 4 clips, because otherwise it becomes very difficult for the radiation oncologist to give the radiation post-surgery. And then they tend to go to try to look for the seroma cavity, which is not always just above where you need to be giving the boost post breast conservation. Now, how much margin to take? There's a beautiful paper by Dr. Monica Morrow, and which is actually a review article, and it gives consensus guidelines, which tells us that in invasive carcinoma, no ink on tumor is enough. But because there is difference in the growth pattern and utilization of systemic therapy in DCIS or ductal carcinoma in situ, it is important that you get 2 millimeters of margin. A wider negative margin do not improve local control for DCIS or invasive carcinoma when they're treated with lumpectomy and RT. Now, since we have moved from mastectomy towards breast conservation, similarly, in axilla, we have moved from an era, from axillary lymph node dissection to sentinel lymph node biopsy or axillary conservation. We do it a little differently here in Tata Hospital. I'll come back to that again. So what do you do in sentinel lymph node biopsy? In a the sentinel lymph node is called the gatekeeper of the area that it drains. So it is supposed to be the first node. Anatomically, it is supposed to be the first node that receives the cancer cell via the lymphatics when it starts traveling from the tumor towards the lymph nodes. So most of the time, the sentinel lymph node in the breast is going to be an axillary lymph node. So what we do is that we inject a blue dye and a radiocolloid, which is the technetium labeled sulfur colloid. And the technetium labeled sulfur colloid is injected on the morning of the surgery. It can be injected a day prior, provided if you have a heavier molecule. And the blue dye is injected just before the surgery, or on the table after the patient has been intubated or has been put under anesthesia. And we wait for about 5 minutes after giving what the dye that we use is methylene blue. We also have started using ICG for this purpose, and I think Dr. Shalaka will be talking about it after this. So I'm only going to stick to blue dye and the radiocolloid, which is commonly used. We use a gamma probe to see where the uptake in the axilla is, and if there is an uptake or radioactivity which can be seen on the gamma probe, then we make an incision over that area and try to take out the hot node and the blue node from that area. So we will be taking out all the hot nodes, all the blue nodes, and if there are, and since the axilla is now open, we also palpate the remaining axilla, and if there are any suspicious palpable nodes, we take them out also. Now, that is sent for a frozen section examination. If the frozen section examination comes positive, we clear the axilla. Now, the role of sentinel lymph node biopsy is identification of a node which is the sentinel node. It may or may not be positive. So this is a landmark paper which brought sentinel lymph node into the surgical field. This is the clinical, they took clinically node negative, about 5,000 clinically node negative breast cancer patients and stratified them on the basis of age, tumor size, type, or surgery. And they did sentinel lymph node plus axillary dissection, randomized them to sentinel lymph node plus axillary dissection versus sentinel lymph node biopsy alone. And they did, in the second arm, they did axillary dissection only if the sentinel lymph node was positive. What they saw was that there was no difference in survival. Sentinel lymph nodes were hot, blue, or palpable, and the identification rate was 97%, and the false negative rate was 9.8%. Based on this trial, it was decided that the false negative rate of 10% is acceptable for sentinel lymph node biopsy. Now, when we see the results, we see that I want you to see the highlighted areas, the regional nodal recurrences in the sentinel node resection and the sentinel node resection plus axillary dissections are not very, there's not a gross difference there. But if you see in absolute numbers, you may see a little bit of difference. But when you see the alive event-free survival, you will see that they are almost similar, 84.1% versus 83.3%. Now, what we do here more commonly than sentinel lymph node biopsy is low axillary sampling. Low axillary sampling has the benefit that you don't need a radiocolloid to be injected. And this is because we train a lot of students at Tata Memorial Hospital, and not everybody is able to have a nuclear medicine lab in their facility where radiocolloid injection can be given and a gamma probe is available. Hence, this is an anatomical template that we use with the boundaries are where it's the intercostobranchial nerve. In the axilla, below we dissect out the low axilla below the intercostobranchial nerve, and we try and dissect out at least 6 nodes, because in the first paper we were able to, which was published by Dr. Vani Parmar, and we were able to see that 5-node low axillary sampling achieved a false negative rate of about 8.8%, and a 6-node low axillary sampling achieved a rate of a false negative rate of less than 2%. Now, if you see in the photograph, there's a blue node mentioned there because at that time we were doing it blue dye guided low axillary sampling. There was another paper that we published again by Dr. Vani Parmar and team, and that was on 478 patients. And if you see the p-value, it is the false negative rate between the sentinel lymph node biopsy versus low axillary sampling. There is no difference in false negative rate, and hence we started practicing low axillary sampling in our regular clinical practice. And sentinel lymph node biopsies are also done at Tata Hospital using multiple dyes, as in a combination of any two. So it could be ICG plus blue, ICG plus radiocolloid, or radiocolloid plus blue. Now, what if your axillary conservation yields a positive node? What do you do next? So there is a study with, this is again a landmark paper, the ECOSOC Z11 paper, which included T1, T2 breast cancer tumors, and these were on sentinel lymph node biopsy, had less than 3 sentinel lymph node positive, and they stratified them on the basis of age, tumor size, and hormone receptor status, and they randomized them to axillary nodal dissection versus only sentinel nodal dissection. Now, when you see the results of these patients, you see that there is no significant difference in the overall survival arm or the disease-free survival arm. But what is to note in this case is that 70% of their population, of the study population, was T1, 80% were hormone receptor positive, and 50% had grade 2 tumors, with a median pathological tumor size of only 1.6 to 1.7 centimeters. Now, this may be a very difficult situation or a difficult patient to get in our countries. We tend to see almost 50% of our patients who are operable breast cancers, and very small number of our patients are less than grade 3 tumors. So leaving behind axilla after a sentinel lymph node biopsy is not something that we, after a sentinel lymph node biopsy is positive, is generally we do not practice that. If it is a micrometastatic disease, or if on the IHC or on the final histopath report you see that it is a micrometastatic disease only, that is the only time when we don't dissect the axilla completely after a sentinel lymph node biopsy positive. Now, in case a patient that fits into the inclusion criteria of ECOSOC Z11, we consider an informed decision with the patient, and after having an MDT, that this patient can be observed, and only then we observe these patients. Otherwise, axillary dissection is what we follow in a positive axilla. Now, this was about breast conservation in operable breast cancer. What do you do in locally advanced breast cancer? So there was a study published. Which showed. Yes, I know I have 5 minutes. I want to finish in next 5 minutes. Yes. Okay. So this was a 3-year local DFS in conservation done in locally advanced breast cancer post chemotherapy, and we found that the 3-year local disease-free survival was actually better in breast conservation as compared to mastectomy. Now, does that mean that breast conservation is better done after locally advanced breast cancer? But actually, no. What these patients were the ones who actually had responded to chemotherapy, so they showed that they were of better biology. In fact, there's an EBC-TCG meta-analysis which has been published of 10 trials, including 4,756 women, where they saw where the primary outcomes were tumor response, extent to local therapy, and distant recurrence, breast cancer death, and overall mortality. And what they saw was there was a significant detriment in local control post neoadjuvant chemotherapy. But the authors themselves said that there were some trials which did not do surgery post neoadjuvant chemotherapy, thinking that they had achieved complete clinical radiologically complete response, and there was poor localization of tumor post neoadjuvant chemotherapy. Hence, this area true locally advanced breast conservation post locally advanced breast cancer is a little gray, and the data available is not absolutely clear on whether it is safe to do a breast conservation surgery post locally. So in responders, it is safe to do breast conservation surgery, but in true locally advanced breast cancer, it is we are running a randomized control trial in our unit right now for this subset of patients. Now, what do you do? What do you do for metastatic breast cancer? There is a role of metastatic surgery in metastatic breast cancer also, but that role is strictly limited to palliative setting, where there is bleeding and fungation. In fact, there is a study which was published by Dr. Badwe from our hospital, which showed that there was no difference in the overall survival of the patients who had locoregional treatment in the form of surgery and radiotherapy versus when there was no treatment given, locoregional treatment given to metastatic breast cancer patients. A similar study was published by Seema Khan et al., it has been presented in last year's ASCO. It is not yet published, where she also observed the same thing, that there was no benefit of surgery in metastatic breast cancer if it was not done for palliative setting. So the only indication for surgery of the primary in case of metastatic breast cancer is bleeding or fungation, otherwise not. And with that, I conclude my talk, and thanks once again to the organizers for having invited me. And if there are any queries, I'll be happy to take them now, or you could write to me on my email address that I've provided. Thank you.